Good morning, everyone. And Dr. Kote, thank you so much for your introduction. My name is Aki Morikawa. I'm a breast medical oncologist at University of Michigan, and I see familiar faces and first-time faces that I wanted to meet as well today. And I'd like to thank the Komen for supporting my research as well as inviting me today. So as a breast medical oncologist, I take care of all types and all stages of breast cancer patients. But my research is a little bit more focused, and I'll be speaking to you today about the brain metastasis research, which is supported by Komen. Here are my disclosures. People are living longer with metastatic breast cancer. It is estimated based on some research that there will be more people living with this diagnosis. In fact, one of the research papers showed that they estimate even 17% of people will be living beyond 10 years at this point, which is amazing. The next graph over here is a median survival. So median survival being that 50% or half the people are living at the time point which this is plotted. So this is a plot over many years, since 1980s to 2010. As you see the black line going up and up and up, so this is a great sign that people are living longer, and we hope this trend will continue as well. And we think this is partly because we have more drugs. And this is the example listing of some of the drugs that's being approved or used in recurrent metastatic breast cancer patients. Initially in 1970s, we had sort of limited list of chemotherapy drugs, which you may have seen: cyclophosphamide, doxorubicin, anthracycline. Some people call it red devils. And then there was sort of quiet period in between, and after 1990s and really after 2000, we saw many more drugs coming out. And not just chemotherapy, but really targeted drugs. And these targets are estrogen receptor pathway, the hormone receptor pathway, as well as HR2, HER2, the growth pathway. So we've seen a lot, and finally for breast cancer patient, we got the immunotherapy going. I know many of my patients were asking about immunotherapy, so atezolizumab, or Tecentriq, was just approved recently for certain type of triple-negative breast cancer. Not for everyone at this point, but hopefully soon. And if you see the curve again for the median survival, you see it sort of correlates. Between 1980 and 1990, it was kind of flat, black lines kind of flat, and then you start to see gradual increase. And that sort of matches up with how many more drug therapy we have to use and treat these breast cancer patients. And I hope that in the future, this trend will go up, and of course, our hope is that we'll be curing patients, and the median survival is going to be long up there, going high. So what does the advance look like? And I'm going to use HR2, HER2 positive disease as an example of what the success looks like. This is a clinical trial called Cleopatra trial. This was the trial that made the pertuzumab, or Perjeta, you may know as a Perjeta, got approved, and we started using this drug. So this was a trial where patients were previously untreated, and they had HER2 positive advanced metastatic breast cancer or recurrent breast cancer. They were randomized, so coin flipped, into getting this drug called pertuzumab or Perjeta along with the standard care treatment at that point, which was chemotherapy with another anti-HER2 therapy called trastuzumab or Herceptin. So this was a triple combination, triple drugs versus 2 drugs. So these were coin flipped and followed over time to see how well the cancer was controlled and how long women lived. So this is the updated data for the overall survival, so how long women lived. So the red line is Perjeta, so patients who got Perjeta medication, and blue is who didn't. As you see, there's a separation, and I think that's a pretty good separation. So this is over a month. So if you look at the 60 point, that's about 5 years. And when you look at the median overall survival, meaning about half the people are still living, with Perjeta group, it was about 56 months, and with placebo group, so kind of sugar pill, no Perjeta group, 40.8 months. So this was a difference of more than 1 year, and this was amazing. And this is the example of how drug therapy, new targeted therapy could really make a difference in extending survival of breast cancer patients. Now, unfortunately, we're not really doing great in some of the areas, and this is where I'm focusing on, where advance is really lagging behind. Now, this is again HER2 positive breast cancer patients. These are metastatic breast cancer patients in the registry called CIST-HERS. These were women who were diagnosed between 2012 and 2016. They wanted to see, we knew that brain metastasis and left meningeal metastases, those are called CNS, or central nervous system metastasis. These women were becoming more prominent, and we recognized that these were unmet need. But we want to see in real life, well, how are the patients doing? So this was a registry. Women got enrolled in the registry, and then they were followed over time. So the graph is showing the proportion surviving, again, against month. So if you look around the 60-month point, which is about 5 years, you see a big separation between blue and black and red. So red line is where patients were diagnosed with CNS metastasis, either brain or left meningeal disease, at the time of initial diagnosis. Black is where they were diagnosed at some point in their lifetime with CNS metastasis, as opposed to blue line, which is they were never diagnosed at the time of follow-up. So initially it seemed that blue and black were sort of similar, and red was sort of lower. But over time, if you look at it, there is really a big difference of having CNS metastasis or not. And this is a survival difference. And if you look at the blue line at 60-month point, more than 50% of people are still living. So this is living beyond 5 years. So this is a big difference. And this is a big gap that I like to fill with my research. Today I'm going to focus on brain metastasis. When people get brain scans, this may look like this. Multiple spots, could be tiny spot, could be a large big spot with swelling. Many women will present with some kind of symptoms. It could be headache, dizziness, vision changes, sometimes weakness, almost like a stroke-like symptoms, but not everyone. And just to clarify, because some people will be confused with brain cancer and brain metastasis, these are separate diagnoses. Brain metastasis, I'm talking about cancer starting outside the brain. So cancer starting as a lung cancer, breast cancer, melanoma, and spreading to the brain, as opposed to brain cancer, which starts in the brain and stays in the brain. Treatments are very different, so I wanted to clarify that, because it could be that metastatic breast cancer may get brain cancer, and the treatment is going to be very different. The way we think how this happens is that cancer grows up in the breast, and some of the cancer cells are smart enough and be aggressive enough to grow and invade into the blood vessels and use it as a highway to travel to the brain. And not all, but some of the cancer cells, again, somehow they're unique and decide, I'm going to stay here in the brain. I like here. I'm going to invade it through the blood vessels. I'm going to set up home and starts growing. We think this is how it happens, but we don't know exactly how and why. And how often does it happen? So of all the solid tumor patients, we think breast is the second most common cancer to travel to the brain. Lung is the most common, breast is second. So not all cancer types are equally seeing the brain metastasis. Really, breast is one of the most common ones. And we think it's increasing. Some researchers have proposed that it's because we're using more MRI brain scans as opposed to CT scans, because MRI is much more sensitive in picking up small spots. Other people suggest that people are just living longer, because we know that longer and longer you survive as a metastatic breast cancer patients, there's a higher likelihood that brain metastasis may pop up sometime in lifetime. Especially this is true for ER-positive, HER2-negative cancer patients when we detect brain metastasis mostly after many lines of treatment or therapies. So we're thinking that this might be increasing in instance. At this point in time, we estimate about 15 to 20% of patients will develop brain metastasis. So thankfully, this is not majority of people, but this is a significant portion of patients that we don't want to ignore. Especially this is high risk for certain type of breast cancer patients. So studies have shown anywhere from 30 to 50% of triple negative and HER2 positive patients may be at risk. Now, I think 50% is a little bit on the high side, but this was a data coming from a big academic center where they were having a lot of brain metastasis studies and trials. So I think people are just traveling all over from the country to go there. So I think 30% is more likely, but that's been published. If we're more likely to be diagnosed. So these are some of the risk factors the researchers have noted at the time of metastatic breast cancer diagnosis, not the one they're initially diagnosed. So younger age, being ER negative, being HER2 positive, higher grade. So grade is that the pathologists score your tumors under the microscope to see how ugly or aggressive looking they are, and goes 1, 2, 3, 3 being the highest grade. And also they've noted that people who get more metastases to lung tend to have more brain metastasis, and also higher number of metastatic sites, meaning that if you compare people with just bone metastasis as opposed to people with bone, lung, and bone, lung, and liver metastasis, so more number of sites that associate with having brain metastasis. And how do we treat it now? It's really a multidisciplinary approach, meaning that it's not just your medical oncologist who's going to take care of it. It's going to be a team effort. Usually it's radiation oncologist, medical oncologist, and oftentimes it's a neurosurgeon's decision to come up with the best plan, best sequencing of the treatments. So we use local therapy that may include surgery in some people, and oftentimes radiation. Radiation comes with whole brain or focal radiation called SRS. And that kind of treats the brain part only. It really doesn't take care of the body. So we can't forget about the body part. This is a systemic disease. So we also use systemic therapy, drug therapy at times, mainly to control the disease outside the brain, but now we're using more and more for the brain as well when we run out of option with radiation or surgery. Supportive care may include steroid use to reduce the swelling in the brain or inflammation in the brain, and sometimes we use anti-seizure medication if some people have seizure. And there is no drug therapy that's currently specifically approved for indication brain metastasis treatment in breast cancer. And systemic therapy or drug therapy, which we think of as a first line in someone who has bone metastasis or liver metastasis, lung metastasis, we don't usually think of as a first line or first treatment option in brain metastasis at this point. And that may change in the future, but not up to this point. And why is that? So historically, we think drug exposure in the brain is quite limited, and limited by a protective covering called blood-brain barrier. So the blood-brain barrier, as seen in a picture, is essentially really not an actual barrier per se, but it's how we describe the blood flow system in the brain. So molecule, remember, cancer cells and molecule travel in the brain and goes to there. So there is a really tight-knit blood vessel system in the brain where only small molecules could go escape in between these wall of the blood vessels. And large molecules are limited to go out there. which actually is a good system if you think about it in a normal life. You don't want all the things that you ingest or you inject or you absorb to go to the brain and make you kind of sleepy or drowsy or affect your mentation. So this is a really protective mechanism for the brain. And you can't really much have place to swell up either because you have a skull, so it's a limited space. So it's a protective mechanism that may play against when you need to use a drug therapy. And the other issue is that patients with active brain metastasis, active meaning that these are the patients whose brain metastasis are actively growing, they were often excluded from clinical trials, drug therapy trials. So we didn't really have information. Are the drugs that we're using, chemotherapy we were using a long time ago, are they even safe? And are they going to even work? We didn't know. Not that we knew for sure that they didn't work, we just didn't have information. Also, much of the lab-based research hasn't really used the brain metastatic cancer cells to do a testing or work on them. So we didn't really have much information about what's going on with these cancer cells, why are they living in the brain, why are they happy in the brain and living there. So we had lots of unknowns. So I think essentially the barriers to improving treatment for brain metastasis lies in a couple of barriers that we could potentially address. One is really to have a better understanding. We really don't understand why certain cancer cells spread to the brain. Remember, not everyone gets brain metastasis. Only a subset of patients do. And we know from certain studies, only a subset of cancer cells go there. So not all cancer cells go there. And what is so unique about these cancer cells? We really don't know very much about it. And two, limited drug efficacy data. Unless we test them, unless we look at them, we don't know these drugs going to work or these drugs do not work. We just don't have information. So we really need to start testing these drugs against brain metastasis cancer cells, and we need to allow patients to be on clinical trials so we know if they're safe, if they're effective. So these are the points I wanted to address in my research. So I'm taking 3 approaches. One is to improve understanding of why these cancer cells go to the brain. 2, to see what drugs work. Are they going to work at all? And 3, to really take an initiative to open up brain metastasis trials and provide opportunity for these patients when available. The first part is learning more about these breast metastasis cancer cells. By learning about them, we could potentially find new treatments, new drug targets. We could potentially discover a way to actually prevent them from spreading to the brain, or understand why certain things are not working, so we could address that problem. And we've used this approach in cancer for many, many years, looking at genomic and molecular characteristics of cancer cells. We look at molecules like DNA, RNA, and proteins in cancer cells, try to see what's so unique about them, identify the changes, alterations, and then see if those could be a good target to treat and stop them. I'm going to go through some examples. So just to think about cancer cells are not normal. They abnormally grow and divide quickly and gets bigger and control growth. So when you look inside a cell in our body, so trillions of millions of thousands of them make up our body, and they essentially have to work well and function to make our body work. And I found this analogy online, which I thought was pretty interesting and good. This is an analogy on cooking or baking chocolate chip cookies. So our cell has DNA and genes. They're essentially the instruction in your body, like a master cookbook. Has a cookbook with many, many recipes on how to make certain products or baking, chocolate chip, cakes, whatever we need to make for the body. So DNA and genes give you instructions. It's like a master book, and they're transcribed to RNAs. There's sort of like specific recipes that you're going to take out to get to the product you want to make, okay? And then some of the products, ingredients get mixed into it, just like a baking. And protein molecules, the ones that you want. And those are the sort of proteins and molecules that make your body work and function appropriately. And that's sort of like a chocolate chip cookie. And anything could happen in any of these steps. Mistakes, damage, for example, radiation chemical could damage the DNA and have a bad instruction. So you make a bad types of protein molecule and you stop functioning the way you're supposed to function. It could be that the recipe was translated or copied wrong, right? You're supposed to make a pound of cookies, but somehow you're told you need to make 100 pounds of cookies, the recipe said. So you make extra cookies or extra proteins, and you shouldn't be having those. Let's say those proteins are the molecule that says your cells need to grow. Well, that's wrong, and that's how cancer cell could start growing and make a mistake. So any of these steps could happen. And that's why learning about what happens in DNA, RNA, protein every step of the way helps us understand what went wrong. Why are these acting not normally? So this is the success story of HER2, HR2. Just going back to Pagetta's story, remember we knew that normal cells had HER2, HR2 receptors. And there were normal amount of HER2. They were growing happy and normally and dividing like it should be. And the cancer researchers discovered that, hey, wait a minute, these cancer cells have so many HER2 receptors. We shouldn't be having this much receptors, that's too much HER2. And we saw that they were growing much faster and growing much quicker than they were supposed to. So really smart researchers before me have discovered that, well, the HER2 receptor actually give a signal about how to grow. So those are growth factor signals. And they were smart, again, to say, well, maybe we should target these HER2 receptors if they're giving signal and they're having too much of it. And then they worked with pharma to come up with many drug therapies, and those you may have heard, trastuzumab, Herceptin, pertuzumab or Perjeta, or lapatinib, Tycarb, or TDM1, which is called Kadcyla. And they matched up targets and drugs. And that was a good match. As you saw in the Perjeta Cleopatra trial, it's shown to improve survival. Okay? So this was a successful match. So this way of approaching cancer treatment has been around for many years because Herceptin has been around for many years. But it's really becoming more popular to look at genetic and molecular changes. It's called precision medicine, you may have heard, or some people call it personal medicine approach to cancer treatment. And this is the approach where cancer treatments are customized to genomic or molecular characteristics of patient, you themselves, genetics that you're born with, or cancer cells from patients. So these are specific to cancer cells in your body. And many clinical trials are ongoing, really for patients without active brain metastasis, and they're finding targets by looking at cancer cell molecules and trying to find drugs that match that target. And we've seen some success, but not all of them, unfortunately. Examples include NCI match trial or ASCO taper trials. Those are called basket or match trials that they are all available in Michigan, throughout Michigan. So what does that look like in real clinical practice? And you may have all experienced this, but for those of you who haven't, this is how we sometimes approach it. We, as an oncologist or as your patient, you request the tumor profiling to be done. These are molecular testing of tumors. We could do it from tissue samples from your surgery or biopsy or sometimes blood. And we send it off to a lab. Could be research lab or commercially available testing lab. Examples include Foundation Medicine, Caris, Tempest, Garden. And has our own Research My OncoSeq panel. So what happens in a simple picture is that you take a cancer sample, let's say from the liver, send it off to the company, your doctor's going to order a form, sign a form to have it sent back to the company, and they extract DNA from the cells. And they kind of fragment them and make multiple copies, and magically with the advance of science, they put it in a machine and they spits up all the data about characteristics of your DNA. And they get analyzed. And what we get back is a report. If they find a molecular alteration, they will report it. Then we look for a match, see if any drugs are available that targets the specific alteration. And these drugs may be FDA approved for your condition, or maybe for other type of cancer, or could be in clinical trials somewhere, not locally, maybe somewhere around the US, or maybe even overseas. Or maybe not even under clinical research, meaning it's only still limited to lab-based research. So this is an example from Foundation Medicine website of the report that we might see. This is for lung cancer, not breast cancer. But for example, they will report the genomic finding, in this case called EGFR mutation. This is one of the common mutations we see in lung cancer, and they will report drugs that are currently approved. So these are approved medication for lung cancer. You don't need to go through trials. They're available. And then they might find additional mutation that will list up below there with multiple alphabet soups, and they will list maybe a listing of trials or some research study that's been ongoing to suggest what the pathway or targets may be. So this is how we see as a clinician. So this has been an approach, and we're using this approach in breast cancer brain metastasis. So learning about cancer cells unique to go into the brain, looking at DNA, RNA, proteins, and I'm comparing molecular characteristics of brain metastasis cancer cells compared to the original breast cancer cells that started it, to see what the unique populations are. So this is the head-to-body comparison. I'm also comparing cancer cells from patients who had brain metastasis as opposed to who did not develop brain metastasis, to see what are so different about these cancer between these patients. Now, I still haven't completed the final analysis, but I could tell a little bit early observation is that brain metastases do contain some unique, potentially drug-targetable mutations. And we think, and this is consistent with other researchers around the world, and we think precision medicine approach may be useful in treating brain metastases, active brain metastases, and having patients enroll in such trials. And in fact, there's an initiative to open up those match trials, sort of match-like trials for patients with active brain metastasis. I believe one is being opened right now, and I hope another one is opening soon. So if you remember my older slides, I said we don't like to use drug therapy because we don't know how well they work, right? So that's a great question if you remember that slide. So you might say, what about the blood-brain barrier? Because how are we going to get these drugs into there? Or are they going into the brain metastasis at all? So that's the question I'm asking in my second attempt to look at drug therapy in brain metastasis. So drug therapy has to get there, right? Go into the brain metastasis. Even if you get there, it has to work. So are the targets really the true targets for these drug therapy? And these are the questions I'm looking into. So this was a study completed at Sloan Kettering. This was a study looking at drug exposure in brain metastasis. We enrolled approach breast cancer patients who were undergoing to get brain metastasis resected for regular clinical indication that their neurosurgeons say we should take this tumor out. We gave 1 to 4 doses or days of capecitabine, that's a chemotherapy pill, you may have heard Xeloda, or lapatinib, otherwise known as Tykerb, that's a HER2 small targeted molecule pill, to patients before going to surgery. The surgeon took them to surgery for regular treatment. We got the sample of the tumor, extra sample, and we sent it to the lab to get drug tests level tested, just to see are these drugs going in there if we give it a few days before the surgery. Yes, it did. And this, we had seen from the mouse models that some of the drugs do get into the brain metastasis, but we really saw this in breast cancer patients. The Xeloda, capecitabine, and lapatinib did get in. However, unfortunately, it was not all consistent level, and unfortunately, it wasn't the highest level that we wanted to in many patients. So this is the example of capecitabine or Xeloda drug levels from 2 patients. We took multiple samples from each patient. So all the bars, different color bars, are different samples from one patient. So C6 has multiple colored bars. Those are different samples from the same person, as well as C7. So capecitabine or Xeloda pill go through a metabolism in your body or in the cancer cells and become the active chemotherapy called 5-FU. 5-FU, 5-fluorouracil, you may have heard as a part of chemotherapy called CMF for some patients. So it's been around for many years. That IV chemotherapy got into a pill form, and that's called Xeloda or capecitabine. So 5-DFCR, 5-FUR, 5-FU, those are each step on the way the Xeloda pill gets converted to finally to 5-FU active form. So when we looked at the patient C6, you see the capecitabine level is quite low, but it gets converted over time into the active form 5-FU. But if you look at different bars, they're not all equal. There are some samples that have really high, much higher level than other ones. So there's a difference in variation within person, the tumor. In the C7, it was a little bit more uniform. It was a little bit higher in terms of level of capecitabine and active form 5-FU compared to C6. So, there is a difference between patients and difference within patients. But we don't know why. Is it the amount of blood-brain barrier that's been damaged? It could possibly be. So that was really interesting. So we know that they get in, but maybe not perfect level. And for the drug testing to see if they work, we're using avatars. Now, some people may have seen the movie Avatar, or they've seen, if they go online or do gaming, do you have an avatar for shopping or shopper or games? So essentially, it's a virtual reality of people. So cancer researchers are nowadays using these avatars for drug testing. And you might say, what? Virtual reality? Actually, we're using mouse. So they're called patient-derived xenografts. So these are cancer mouse avatars. What happens is we take a sample of cancer from person and implant it in mice. Mice are usually immunocompromised, so they grow the cancer cells quickly, as quick as they can. So we have multiple mouse embedded with cancer cells. And then we could test different types of drug at the same time to see which one works. This is an advantage over giving a person 100 different drugs at the same time, because we could probably kill that person by giving 100 drugs, but also we don't know if it works, which one did it work. So this is the way to kind of look at the different drugs at the same time, so a parallel approach to looking at drug therapy and drug responsiveness. And this is the approach we've been using for brain metastasis. So again, we identify patients who are going to surgery to get their brain metastasis removed. We collect the brain tumor tissue, implant it in mice, and the mice, they grow as a patient-derived xenograft tumors. And once they grow up in mice, we take a sample, and in the lab, we test up to 400 different drugs at a time. In addition, we collect some information about the patient or tumor just to see are there any targets that were available, what kind of treatment these patients get before, and correlate what happens. And this is one of the preliminary example. So this was a cancer cells taken from a triple-negative breast cancer patient who was also BRCA1 positive mutation. And molecular profiling also showed BRCA1 mutation. The importance of BRCA1 mutation is that it's a genetic condition where we do have an FDA-approved targeted medication for this pathway. So as a standard care, this patient received PARP inhibitor called olaparib. This is a small molecule. Unfortunately, her brain metastasis grew while she was taking this medication. So we again collected this tumor where she was gonna go for surgery and then created mouse avatar. Tested up to 400 drugs. So this is the example of drug testing result here. So on the side, you'll see percentage of cancer cells alive. So 100 means that all the cancer cells are still alive despite drug treatment, meaning they're resistant. And the concentration drugs is plotted on the bottom. So higher you go on the side, towards the side, that means the drug's higher concentration. So maybe the drug may work at the higher concentration, but may not be safe for the patient. Could be toxic. So olaparib is the green line. This is the drug the brain metastasis grew on. As you see, it's pretty flat. Niraparib and talazoparib are cousins of olaparib. They function in a very similar way, targeting as a PARP inhibitor. And they didn't do great either, which is consistent that this was resistant. As opposed to, we've picked up one of the research drug called AZD7762, which also targets the same BRCA1 mechanism, but not exactly as a PARP inhibitor. It seems to show that they work, this drug works a little bit better, but not perfectly because, even at the higher dose, it's not killing up 100% of cells. So this drug will probably treat it, but not going to cure this cancer. Just showing that metastatic breast cancer is really difficult to treat. So what we learned from this preliminary experience is that, good, we're able to grow these cancer cells and test drug response. Interesting, we tested up to 400 drugs. Not all drug target matches are great, which is consistent with what we've been seeing in clinical trials. And not so good was that for mouse avatar, it took months and months and months to grow. So we didn't get any result for several months out. And that may not be really helpful for patient care if you think about it, if this becomes a real thing. So what's next? And this is where Komen is supporting my work. And this is where Evelyn sitting here has helped me shape my research. So finally, this is funded. We're going to be starting this study. So we again go to the operating room, collect samples. This is exactly the same scenario I showed you before. What's different? It's going to be different because we're going to cut the avatar out. We're going to go directly from the tumor to the lab testing. And we do this by using a new technique called 3D suspension cell culturing called organoids, patient-derived organoids, to see if we could do this approach and keep the cells living long enough and fresh enough and represent the cancer enough to the point we could do a drug response testing and be relevant to the patients. So the goal of this project, this is really early stage in the game, so really looking at how quickly and successfully we could do this testing and see if we get the result. And to make sure that what we're testing is going to eventually be correlating with what happened with the patients. So this is a long-term project. And I'd like to thank the Komen again for supporting this project. And as a reminder, this is research, and we still need to go far away, so please don't go to your oncologist Monday and say, I want my mouse avatar ordered. So we're not there yet. Hopefully, maybe, in the future. And again, I said, most people won't get brain metastasis, and I hope you'll never get it. For those of patients right? We estimate only 10 to 20, 15, 20% maybe will develop brain metastasis. So for those patients without brain metastasis, this approach could still be useful. Useful maybe in other sites of metastasis like liver or lung, primary breast tumor, or other types of breast cancer. And actually my colleagues are working on bladder cancer right now, so it'll be very interesting to see how that works out. The third initiative is to increase opportunity for brain metastasis clinical trial. So ASCO, the American Society of Clinical Oncology, Friends of Cancer Research, and most recently FDA has recognized this is an important problem. They think this is where we're behind in some parts. And if you ever seen or consent form for the clinical trials, or you've tried to get on clinical trial, there's so many checklists that you have to pass through. So there's really initiative to open up the many patients possible. And one of the area is for brain metastasis patients. These are not treated and brain metastasis that's stable. This is really brain metastasis are active and growing. So the initiative is to really open up trials and open up eligibility criteria to allow these patients onto trial. It doesn't have to be brain metastasis specific trials. It could be a regular clinical trial testing drugs, but just allow those patients to be on it. And we're really taking initiative to open these type of trials at University of Michigan. So these are the examples that we just had or are ongoing. So we did the phase 1 study of intermittent high-dose lapatinib and capecitabine. Remember, I was looking at the dose of lapatinib and capecitabine in the brain tumor, brain metastasis cells. It wasn't optimal, so we tried the higher dose to see the safe dosing. As phase 1, we're just looking at the safety of it and coming up with the dosing, so we don't have the efficacy result. We also just finished abemaciclib or Verzenio. This is a CDK4/6 inhibitor that's already approved for breast cancer patients. They've seen earlier trials that this molecule may go into the brain or spinal fluids, so they were looking to see how effective this is. The results been reported earlier, but it hasn't been finally published, so we'll be waiting for that. We have one that's called phase 2 of neratinib and capecitabine, but actually the current open version is neratinib Nerlynx with trastuzumab emtansine, which is Kadcyla. So this is our Nerlynx and Kadcyla combination trial for brain metastasis patients that's open. This is for HER2-positive patients only. And we're anticipating that we'll be opening more trials that allows patients with active brain metastasis. And I'm really fortunate to be surrounded by many, many collaborators and cancer specialists who are really keen on targeting this problem, brain metastasis. I work with neurosurgeon Dr. Hath and radiation oncologist Dr. Kim. We provide a multidisciplinary care coordination. In the neurosurgery, we actually have a brain metastasis clinic, that's special clinic. And we work on research and clinical trials, and Dr. Mariver Solner and Dr. Merrill are the researchers working on the COMET project with me. And the ultimate goal is to really decrease mortality and morbidity associated with this condition. So remember this graph from before where there was a difference? The goal is to close this gap. So in summary, I talked to you a lot about brain metastasis and a lot of information, but I sort of want to summarize the 3 simple messages. If you don't remember anything from my talk, that's okay. It's a lot of information and kind of professional terms. Brain metastasis treatment is really multidisciplinary, so you want your team to be a multidisciplinary team and have everyone do a care coordination. Not just one doctor doing the medical oncology part, radiation oncology part. Make sure they're all on the same page, coming up with a good plan for you. It is an area of active research, and I always, encourage clinical trial participation. I know that clinical trial may not be available to you or may not be suitable, but please think about it when it's appropriate and it's reasonable. because smart researchers could do a lot of smart research in the lab, but unless it carries over through clinical trials, I'm not going to have that tool to treat patients. So really, clinical trials bring out and get the drugs approved and used in the clinic setting. Okay. And I'd like to acknowledge my mentors, collaborators, and patient advocates, as well as research support. I highlighted the Komen project group. And finally, most importantly, all the patients who contributed to our research, because without them, I don't have any of these data to show you today. Okay. Well, thank you everyone for your attention, and thank you, Komen, for inviting me today.